So we talked about these types, these branched amino acids. These are the leucine, isoleucine, and valine. These are metabolized by this enzyme known as the branch chain alpha keto acid dehydrogenase, which requires this vitamin B1 acids cofactor. Remember, I told you the functions of vitamin B1. Every dehydrogenase enzyme requires this vitamin B1, and that transketolase enzyme, which is in the this HMP shunt, the pentose phosphate pathway, right? So this is a function of vitamin B1. Now, these isoleucine, leucine, and valine, with the help of this enzyme branch chain keto acid dehydrogenase, they convert it into the propionyl coenzyme A. Okay. Then the propionyl coenzyme A will be converted into this methyl malonyl coenzyme A. And with the help of this vitamin B12, this methyl malonyl coenzyme A will be converted into the succinyl coenzyme A. Okay. And this leucine will be converted into the acetyl coenzyme A with the help of this same enzyme, branch chain keto acid dehydrogenase. This leucine will be converted into the acetyl coenzyme A, and rest isoleucine and valine will be converted into the succinyl coenzyme A. Likewise, I told you about this leucine and lysine. These are the ketogenic amino acids only, right? So they will be converted into the acetyl coenzyme A, and rest isoleucine and valine will be converted into the succinyl coenzyme A to enter the TCA. Okay, when the deficiency of this enzyme occurs, you will get the accumulation of this isoleucine, leucine, and valine. And what symptoms you will get is the vomiting, and the most important, or you can what do you call it, the buzzword. Okay, this is the maple syrup like smell of your urine, or the burnt sugar like smell. You should remember this as a buzzword. Okay, the maple syrup smell of your urine, or the burnt sugar smell, or the caramel like smell of your urine. Okay, you can say it like that, the caramel like smell. So the musty body odor is in the phenylketonuria, and the maple syrup like smell is in the maple syrup urine disease. Of course, that's why the name. So the treatment includes a thiamine supplementation, so that the remaining of this enzyme could be activated by this vitamin B1. Okay, and you should restrict the isoleucine, leucine, and valine in your diet. Okay, you will also get the CNS defects that includes the seizures, the lethargy, and the irritability, the intellectual disability you will get, vomiting, nausea you will get, poor feeding you will get, and of course this urine smell, which is very important. Okay, any doubt about this disorder, guys? Any doubt? So we are moving forward with the alkaptonuria, like I told you in the previous slide, that this tyrosine will be converted into the homogenesic acid, which will be later converted into the malallacetic acid, and then the fumarate. And this is the enzyme which is a homogenesic acid oxidase. And if it become deficient, what you will get is the alkaptonuria. You will get the accumulation of this homogenesic acid in your body. It will accumulate in different parts of your body, including your joints, your earlobes, and when it came out of your urine after exposing to the air, it will be converted into some kind of a black substance, and that's why your urine turns black whenever it exposed in the air. So it could be a classical case could be a male child or a female child, and somehow they forgot to flush the toilet, and the parents will see some kind of a black substance in the toilet, and so they will come and tell you the same thing, so that you can know that this must be a case of your alkaptonuria. If the disease remain undiagnosed in the infancy, then in the later adulthood, what you will get due to the accumulation of this substance in your joint, you will get the multiple arthralgias, deliberating arthralgias in your body. You will get the accumulation of this substance in your ear cartilage, so you will get the thickening of the ear. Okay, you will get some bluish, blackish spots all over your body, as you can see here in this figure also. These are the bluish, blackish spot. These are present all over your body, and this is due to deposition of this homogenesic acid in your skin. Okay, this is an autosomal recessive disorder. I told you where the deficiency occur. Okay, so your tyrosine would never be converted into the fumarate. Okay, so severe arthritis in the adulthood you will see. Okay, bluish, blackish deposits all over your skin you will see. Thickening of the ear cartilage you will see. Okay, deposits of this substance in the larger joints and spine will lead to the ankylosis also. Okay, any doubt? I think it is easy. Simple remembering facts. Then comes the homocystinuria. What is a very important fact I told you about this homocystinuria thing? Remember another similar disease?
Marfan syndrome. Marfan syndrome.
Yeah, exactly. Marfan syndrome. The Marfan syndrome and the homocystinuria both will have very similar symptoms, you know, and that's why you called it the Marfan. Yeah.
But the mental retardation will be present in homocystinuria.
Yeah, it is a mental retardation, and plus the subluxation of the lens is in the medial and downward direction, right? So these are the only two changes that you will see in the homocystinuria that will help you differentiate it with the Marfan syndrome. Okay. So what is this?
The cause of death is same in both. The cause of death is same in both.
No, it's different. No, yes, yes. No, actually, it is different. In case of, yeah, in case of this homocystinuria, you will get a thrombotic complication, the myocardial infarction, the stroke, which are the cause of death in this homocystinuria. Because you know this homocysteine is actually very toxic to your blood vessels. Okay, so any damage to your blood vessel will lead to the thrombosis, and you will get this death. Okay. So
and in Marfan syndrome, we were getting mitral valve prolapse, the aortic regurgitation, aortic dilation.
That is the second most common cause. Second most common, not the most common. Most common with dissection of your aorta. Very painful death it will lead to. Yeah, exactly.
Okay.
So what is this homocystinuria and what is this homocysteine? Remember I told you something in the vitamin B12 section that the homocysteine will be converted into the methionine, and at the same time the methyl tetrahydrofolate will be converted into the tetrahydrofolate. Remember?
Yes.
Yeah, and the same thing will be happen when this the homocysteine can also be converted into the cystathione with the help of this enzyme known as the CBS, or the cystathione beta synthetase enzyme. Okay, this enzyme also requires this vitamin B6 as a cofactor. Now after the cystathione is converted, it will convert it into the cysteine. So two ways for the homocysteine, either to become the methionine with the help of two vitamins, that is vitamin B12 as well as a vitamin B9, because you require the vitamin B9 to form this tetrahydrofolate, right? And the second way is to convert it into the cysteine, and that is with the help of this vitamin B6 and the cystathione beta synthetase. So if you get a deficiency of vitamin B12 or the vitamin B9, or you get the deficiency of vitamin B6, what is going to happen? You will get the homocystinuria. If you become deficient of one of these two enzymes, what you will get is the homocystinuria. And let us suppose you get a deficiency of either the vitamin B6 or the CBS enzyme. What will happen? You will get the very high level of this methionine. And if the deficiency of this methionine synthesis or the vitamin B12 occur, you will get the high levels of this cysteine. So the treatment includes to replace the deficiency either by giving the patient vitamin B6 if the deficiency of vitamin B6 happens, or to give the patient vitamin B12 in case of methionine synthesis deficiency or the vitamin B12 deficiency. Okay, and this is the same thing that is written here. Step 1 gonna give you the same reaction, and they will ask you what will happen if this MTHFR enzyme become deficient, which is a methylene tetrahydrofolate reductase enzyme. If the deficiency of this enzyme occur, what will happen? You will get very low store of this tetrahydrofolate enzyme, this methyl tetrahydrofolate. So you will get a deficiency of this methionine. You will get a deficiency of this methionine, and as a result, all of this homocysteine will be converted into the cysteine. So we'll get very high levels of cysteine. That's how they're going to trick you into this fact. They will inhibit one of the enzyme, and they will ask you what other substrate will be rise in the levels. Okay. So all causes are the autosomal recessive. It could be either the cystathione beta synthetase deficiency. So treatment includes to lower the methionine in the diet and to increase the cysteine in the diet, because there's a deficiency of cysteine going to happen, and to give the patient vitamin B6. You can also give the patient vitamin B12 and the folate in the diet. Okay. If the affinity of the cystathione synthetase for the pyridoxal phosphate is decreased, the treatment again includes the giving patient vitamin B6. Okay. Then the deficiency of methionine synthetase could be happen, and this will lead to deficiency of methionine. Okay, so the treatment includes a methionine in the diet, and this methionine will be converted into the S-adenosyl methionine, which is a methyl donor, if you guys remember.
Please repeat the last slide.
This methionine will be later converted into the SAM molecule. Remember S-adenosyl methionine, which is a methyl donor. Remember the vitamin B12 section? I told you in the vitamins.
Last point before that.
My voice is echoing. Please, someone turn off your speaker. Okay, yeah, please repeat. Yeah.
Can you please repeat the last point before that?
The methionine synthesis deficiency.
Yeah, yeah.
If you get a deficiency of methionine synthesis, what's gonna happen? Your homocysteine could not be converted into the methionine, right? It will divert it completely to form the cysteine. You will get very high cysteine levels and you will get very low methionine levels, right? And you also know that this methionine will be ultimately going to convert into the S-adenosyl methionine, right? Same molecule, which is a methyl donor, right? For the imprinting, for the methylation reactions. Remember? Remember?
Yeah, yeah. Yes, yes.
Okay. So that was the facts I told you. And what if you get a deficiency of this methylene tetrahydrofolate reductase enzyme? This enzyme become deficient, so you cannot convert this tetrahydrofolate into the methyl tetrahydrofolate. And as a result, what you will get is a deficiency of again the methionine. So what is the treatment? Treatment is to increase the tetrahydrofolate level so that the remaining enzyme could be activated. Okay.
Okay. Yes.
Okay, so that's about the causes of deficiencies of these enzymes and the homocysteinuria. Then we will talk about the symptoms. Like I told you, this homocysteine is very toxic to the endothelium of your blood vessels. So what you will get is a thrombotic complications. You will get the stroke, you will get the myocardial infarction at very early age. So whenever you encounter a patient who is very little, like 9 years or 10 years, and he's having these multiple attacks of myocardial infarction or the stroke, you will immediately think about this homocysteinuria. Okay, step one is I'm gonna also give you some facts like he's very poor grade, he's having very poor grades in the college or in the class, and he's having this difficulty in looking at the blackboard because of this subluxation of the lens. And they will give you the length of the patient like 6 feet 2 inch or 6 feet 4 inch, and they will give you the patient is having very long hands, long foots, long tapering fingers. Okay, so these are all the symptoms of this homocysteinuria you should remember. And you should also remember that a deficiency of this vitamin B12 and B9 will also lead to the megaloblastic anemia along with this homocysteinuria. So whenever a patient present between 3 to 15 years, you will always think about patient is too young to be having any blood vessel problem. So this must be a case of your homocysteinuria. And thrombotic occlusion is the most common cause of death in the homocysteinuria. You should remember this. Okay. Okay, any doubt in this? Please turn off your mic. Who is this?
Let's turn off our mics.
I think it's yeah, it turned off. Okay, so any doubt in the homocysteinuria?
No.
Any doubt, guys? No? I'm moving forward now. Now let's talk about the cysteinuria. Does anyone know about this cyanide nitroprusside test? Anyone? Cyanide nitroprusside test? Okay, so please write it down in your Excel sheet or the notepad that I asked you in the very first lecture. Every fact that you are missing in the first aid, you can write it down. So please write that this cyanide nitroprusside test is used for the diagnosis of the cysteinuria. Okay. Okay, so cysteinuria occurs due to the deficiency of some transporters in your renal PCT. Okay, there are some transporters in your renal PCT which absorbs this cysteine, this ornithine, this lysine, and the arginine in your urine. Okay, if the deficiency of these transporters occur in the PCT as well as your intestinal epithelium, what will happen? You will lose all of these amino acids: the cysteine, the ornithine, the lysine, and the arginine. Okay, so this is the cysteinuria, and you should also know that cysteine in your urine can cause a cysteine stones. Okay, and these are appear as these hexagonal structures, as you can see here. These are the cysteine stones whenever cysteine is in excess in your urine. So what is the symptoms of this cysteinuria? First of all, the loss of all these amino acids, the recurrent stones in your kidneys. Okay, and what is the symptom of the kidney stones? Can anyone tell me? Symptom of kidney stones?
Colicky pain, nausea, vomiting.
Yeah, the pain that radiates to your groin, right? The pain that radiates to your groin. Okay.
Yes, yes.
Okay, because cystinuria is kind of a some acidic area. Okay, cystine has this very low pK than the pH of your body. So what you're gonna do is you're gonna give the patient urine alkalization. You will do, okay, you will do what? The urine alkalization, so that the cystine will become ionized and it will easily excrete in your urine. It won't form the stones, okay, because you know that cystine stones will form only in the acidic environments. You should know the fact that cystine stones will form only in the acidic environments, and that's why you give the patient alkalization. And that could be done by giving the patient acetazolamide therapy, which is the carbonic anhydrase inhibitors. Okay, so the treatment includes a urinary alkalization and of course the replacement of all of these amino acids in the diet. Okay, and you can also give the patient chelating agents like penicillamine. Okay, and of course, this is an autosomal recessive disease, and cyanide nitroprusside test is a diagnostic. It is a fact you should remember. Okay, and please remember that both kidneys as well as your GIT will be affected, because they both have these transporters. Okay, so any doubt?
Do you remember getting a question on this test, urinary cyanide nitroprusside test?
Yeah, they mentioned this test in the question stem. They will give you some very weird symptoms, and they will give you this buzzword, this hint that the test is positive, and that's how this must be a cystinuria case. Okay, so you can just remember it as a fact that like a buzzword. Okay. Then comes the organic acidemias. Okay, whenever you remember this these steps, the conversion of leucine, isoleucine, valine into propionyl coenzyme A, and then the methylmalonyl coenzyme A, then the succinyl coenzyme A. So please turn off your mic. Who is this? Whose mic is this?
It's Adiwal, everyone.
Maria.
No, there are two mics open probably. It's Adiwal. Probably you can switch off the mic.
Okay, I'm muting everyone. Okay.
I'm not talking.
We can't hear you.
We can't hear the speaker. He muted himself.
We can't hear you.
I'm sorry about that. Yeah, I'm sorry about that. I muted myself. Okay, so remember this reaction again. I'm telling you this reaction that I told you already about this isoleucine and valine, that they are converted into the propionyl coenzyme, then to the methylmalonyl coenzyme, and then to the TCA, the succinyl coenzyme, and then to the TCA. If the deficiency of any enzyme in this pathway occurs, this would lead to the accumulation of these acids inside your body, and this causes the organic acidemias. Okay, and so whenever you have this acid inside your body, what you will get? The high anion gap metabolic acidosis. Okay, so the first symptom is your high anion gap metabolic acidosis. And because you're not going to get the gluconeogenesis again, because the enzyme pathway is inhibited, what you will get is very low glucose level. So you will decrease the fasting blood glucose level. And because you're not getting glucose, your body will try to cover this up by using the ketones. So you will get the ketoacidosis, and this will again contribute to the high anion gap metabolic acidosis. You will get the hepatomegaly, you will get the seizures. There would be the inhibition of the urea cycle happens, and that will lead to the hyperammonia. Okay. So what type of acidemias could be
Why
occurred?
is there this inhibition of the urea cycle? What is the reason behind this?
Well, this happens in every organic acidemia actually. This is a fact.
Okay.
Whenever you get this organic acidemia, you will have this hyperammonia. Always.
Yes, there was a question, but the explanation wasn't given.
Yeah, actually, explanation wasn't given. There was a question only.
Okay.
Sorry about that. Okay, so we continue now. Okay, so now two type of acidemia could be occurring. First is the propionic acidemia, which happens when you cannot convert your propionyl coenzyme A into the methylmalonyl coenzyme A. And the enzyme that involves here is the propionyl coenzyme A carboxylates. Remember, I told you in the vitamin section about this enzyme. It requires the vitamin B7 to function, right? To convert the propionyl coenzyme A into the methylmalonyl coenzyme A. So if you get a deficiency of this enzyme, what's going to happen? You will get very high level of propionic acid in your body, and you will get the very low level of methylmalonic acid in your body, right? And the second deficiency occurs at the mutase enzyme. Remember, this requires a vitamin B12 to function. This mutase enzyme that converts a methylmalonyl coenzyme A into a succinyl coenzyme A. If the deficiency of this enzyme occur, what you will get is the high level of methylmalonyl coenzyme A, high level of propionyl coenzyme A in your body. Okay, again, the similar symptoms, the ketoacidosis, the high and uncapped metabolic acidosis, the hepatomegaly, the seizures, the metabolic acidosis, the fasting blood glucose level, and the hyperammonia. Okay, so what are the treatments that you can give? A very low protein diet would be appreciated. Okay, and especially the diet which is low in valine, isoleucine, threonine, methionine, and or chain fatty acids, because they all will convert it into the propionyl coenzyme. Remember this summary of all this metabolism chapter. Here the short chain fatty acids, the branch chain amino acids, the methionine and the threonine, they all will get converted into the propionyl coenzyme A. So you need to protect this thing, okay? So we'll get a diet which is deficient in these amino acids and fatty acids. That's the treatment of this amino acid this organic acidemias. Okay. Any doubt? Any doubt?
No,
Guys?
you can carry on.
Okay. So now the role of insulin and the glucagon in regulating your glycogen synthesis. Okay. So you need to know how this glucagon actually works. Like I told you already, this glucagon will activate the cyclic AMP, right? It will activate the adenyl cyclase that converts the ATP into the cyclic AMP. The cyclic AMP further downstream activates this protein kinase A. And what is the function of kinase enzymes? To add the phosphate group, right? So what they will do, they will add a phosphate group to the glycogen phosphorylase kinase. And again, because it is a kinase enzyme, it will again add the phosphate group to other enzymes, which is a glycogen phosphorylase. And then this glycogen phosphorylase will add a phosphate group into the glycogen molecule and will convert it. Yeah.
Can you just restart this glycogen regulation if you haven't been for long? I just got disconnected.
Glycogen. Okay, so
Yeah.
we were talking about the function of this insulin and the glycogen. Okay, sorry, glucagon and this insulin. Okay, and what I told you is that this glucagon actually works through the cyclic AMP. It activates the adenyl cyclase. Okay, adenyl cyclase uses the ATP to convert it into the cyclic AMP. This cyclic AMP further activates the protein kinase A. Protein kinase A phosphorylates the enzyme which is the glycogen phosphorylase kinase. And this glycogen phosphorylase kinase will further activate or phosphorylates this glycogen phosphorylase. And this phosphorylase enzyme break down your glycogen into small glucose 1-phosphate molecules. This is the phosphorylase enzyme. So it will add the phosphate. So it will convert the glycogen into glucose 1-phosphate. Okay, and that's how you got the destruction of the glycogen, right? And the insulin, what it do, it will activate the protein phosphatase, which removes the phosphate group. Okay, so what happens is it will remove the phosphate group from the glycogen synthetase so that it could become active and it will convert the glucose into the glycogen. And the same enzyme is inhibited by this protein kinase A. Okay, and this protein phosphatase enzyme also inhibits this enzyme, this glycogen phosphorylase kinase, so that it cannot activate this glycogen phosphorylase enzyme, so that you never get to form the glucose from the glycogen. Okay, you should remember this function of the insulin and the glucagon, how they works.
The phosphatase is removing the phosphate group, and the
Yeah, exactly.
phosphorylase, the phosphorylase is adding the phosphate group.
Exactly. So insulin work by removing the phosphate and activating the glycogen synthetase. And if you remove the phosphate, remember this protein kinase A is actually adding the phosphate in this enzyme, right, to activating it. So if you remove a
Yes.
phosphate from this enzyme, you will inhibit it.
Yes.
So insulin work by removing the phosphate and glucagon act by adding the phosphate. Okay.
When glycogen phosphorylase is activated by glucagon, this will lead to the formation of glucose 1-phosphate.
Glucose 1-phosphate, yes.
And what will
And
ultimately be the fate?
yeah,
What will ultimately be the fate of this glucose 1-phosphate
this
into blood?
this glucose will convert it. This glucose 1-phosphate will be converted into glucose 6-phosphate and then to the glucose, gluconeogenesis. Oh, sorry, the glycolysis pathway to form the glucose again, right?
Okay.
So this will happen into the hungry state, in the hunger state, right? And this will happen in the fed up state when you eat too much just after the eating, okay? And similar to the glucagon, your epinephrine works in the same way. It will again activate the adenyl cyclase enzyme by the beta receptors, okay? And further in the downstream, the same process going on and will further convert the glycogen into the glucose. So epinephrine and glucagon works in the same way. They will increase the blood glucose levels, okay? And in the liver, this epinephrine acts through this alpha receptor also, okay? And further the same thing. It will activate the same enzyme and same process going on again and again. Okay, any doubt in the function of this glucagon and insulin?
In the liver, it activates the alpha receptor, which is acting through endoplasmic reticulum.
In liver, it can activate both alpha as well as the beta receptors, but in muscle, it can only activate the beta receptors.
Okay.
Okay. Yeah.
Sure.
So that's the function of your thyroid. Yeah.
Regarding the organic acidemia, you said the diet should be low in methionine also. However, methionine is not a branched amino acid, isn't that?
Yeah. No. It's not a branched amino acid. What I told you is odd chain fatty acid, branched amino acids, methionine, and threonine. Okay. Odd chain fatty acids, branched chain fatty acid. Sorry, odd chain fatty acid.
Branched chain amino acids.
Yeah, methionine and threonine.
And methionine and threonine. Okay.
Okay, different things. Okay.
We just need to remember why this methionine and threonine is added.
Yeah,
there is no,
and you can think
any
that like vomit.
for that.
There is a this mnemonic you can learn, vomit.
You did not encounter any explanation for that. Okay, we understand.
Yeah,
that
I encountered that. Yeah, I encountered an explanation. Wait, this is somebody given in the first aid, right? Before the start of this metabolism chapter, as you can see here, all of these odd chain fatty acid, branch chain amino acids, and this methionine and threonine, they all converted into propionyl coenzyme A by the action of this vitamin B1.
Okay, yes. I now remember that.
Yeah.
Okay.
Okay, now the glycogen, like I told you, every glycogen molecule will be converted into the glucose 1-phosphate by the action of this glucagon. Please remember this fact. You don't need to know how the synthesis of this glycogen happens. Okay. Just need to know some 1 or 2 enzymes. Okay, the first, we don't need to remember the full pathway. Okay, just need to remember one or two enzymes only. Okay, so the first thing is the conversion of glucose into the glucose 6-phosphate, which is fusion. Then the glucose 6-phosphate will be converted into the glucose 1-phosphate. Okay, the glucose 1-phosphate will be converted into UDP glucose. The UDP glucose will be converted later into the glycogen. Okay, and finally the branching of this glycogen occurs and a complete glycogen is formed and stored inside your body whenever you're in the fed state. Now you should remember the breakdown of this glycogen now, how this breakdown is going to happen. So you need to know whenever you're in the hunger state, there is this glucagon and epinephrine activator system. They will activate an enzyme known as the glycogen phosphorylase, right? The glycogen phosphorylase, which will break down this glycogen right here into the glucose 1-phosphates. Okay, yes. It will liberate the glucose 1-phosphates until the 4 glucose units remain on a branch. It will remove, and once the 1, 2, 3, 4 units of glucose remains on the branch, it will stop. Now what happens is there comes a debranching enzyme. okay, which is a 4-alpha D gluconotransferase. The debranching enzyme is a transferase enzyme, 4-alpha gluconotransferase. It will transfer this chain, leaving one glucose molecule behind. It will transfer it to here, and then again the same glycogen phosphorylase will work until this 4 glucose molecules remains. Okay, and remaining this single molecule of the glucose, this alpha-1,6 glucosidase. Why alpha-1,6 glucosidase? Because it is a 1,6 bond. Okay, and this is a 1,4 bond. Okay, so this alpha-1,6 glucosidase enzyme will act and will remove this remaining glucose molecule. Okay, as you can see here, this one glucose is left after the action of this debranching enzyme. Finally, this alpha-1,6 glucosidase will act and remove this single glucose molecule from here. And again, the same the glycogen phosphorylase will act, remove the glucose 1-phosphates. Okay, that's how the breakdown of the glycogen is done. Okay.
It is only for the 4 chains. It's the 4 subunits left are only on the branch of the chain. Na? The straight chain will be easily cut down by the.
Cleared up. Yes, very easily. Only for the branch it will happen. You know, it will remain like 4 molecules will be left in every branch. Okay. Then the debranching will happen. Then the removal of this alpha-1,6 bond will happen. And again, this glycogen phosphorylase will work and, you know, form this glucose 1-phosphate ultimately. And what happens is this glucose 1-phosphate will be converted into the glucose 6-phosphate again. And with the help of this enzyme, glucose 6-phosphatase, right? Remember, glucose 6-phosphatase enzyme. Where does this enzyme found?
Liver.
No, in the liver where?
Endoplasmic reticulum.
Smooth endoplasmic reticulum, the last step of your gluconeogenesis. Please remember this fact, okay? Finally, glucose will be released inside your blood to maintain the blood glucose levels. Now, what you need to remember is the fact that the deficiency of one of those enzymes will occur. What's going to happen? Okay. So the first is your von Guericke's disease, and that is occurred due to a deficiency of this glucose 6-phosphatase. Okay. The second is your Pompe's disease, which happens because, you know, your lysosomes will also contain an enzyme. Okay. And that is the alpha-1,4 glucosidase enzyme. Your lysosome will also have an enzyme known as alpha-1,4 glucosidase, will remove this 1,4 linkage bond. This is the alpha-1,6 bond, and this is the alpha-1,4 bond. So the enzyme that removes this alpha-1,4 bond will be your alpha-1,4 glucosidase, and the enzyme that removes this alpha-1,6 bond is alpha-1,6 glucosidase. So in lysosomes, there is an enzyme known as the alpha-1,4 glucosidase, which removes this bond, and if it becomes deficient, it causes the Pompe's disease. Similarly, the core.
Okay,
Yeah.
this alpha-1,4 glucosidase is only present in lysosomes. Then
Yeah,
what about
only
this
present.
4-alpha not gluconotransferase, the debranching enzyme?
Yeah, it is different. It does what? It removes the chain from here and adds up here. Okay.
Okay.
A different thing. It removes a chain from here and adds it up here, right?
Okay. Okay.
And then comes the Cory's disease, which occurs due to a deficiency of this either the debranching enzyme or the enzyme involved in this alpha-1,6 bond, removing of this alpha-1,6 bond. Okay. So the enzyme which ultimately causes the debranching will be deficient in the Cory's disease. Okay, so guys, the time is about to be over. So I'm gonna stop the recording here. Okay, I will send you the link again. You guys can join. Okay.